Good afternoon, everybody. My name's Arnold, and my PhD topic is on new perspectives on transplantation in the treatments of cancer and diabetes. So a little bit about myself. I'm a graduate MD and a graduate in biomedical sciences, and currently a first-year PhD and master's student. So my vision is to offer the best medical or surgical options to cancer and diabetic patients and improve the level of healthcare offered in Eastern Europe and more. And my mission to achieve that is to learn from the best in the field, find knowledge gaps, and improve current standards and policies for the treatments of cancer and diabetes. So we've got two projects going on at the moment. One began in September and one last month. So without further ado, the first project is comparing the effect of pancreas and islet transplantation to insulin therapies on glucose metabolism in patients with type 1 diabetes undergoing renal transplant. This is a systematic review and meta-analysis. So, background. Diabetes accounts for around 45% of chronic kidney diseases due to the nephropathy that it causes, and around 40% of diabetics are suitable and listed for renal transplantation. There are currently multiple options that may be combined with renal transplantation. Just a couple of them can be pancreas transplant or islet transplantation, which is actually not as good long-term compared to pancreas transplant. But they are the only cures for type 1 diabetes at the moment. Interestingly, as an idea, there are around 28,000 renal transplants in the US every single year and about just under 1,000 pancreas transplants. Of those pancreas transplants, 96% are either done simultaneously or after renal transplantation. Other therapies, as opposed to transplant, obviously come from the pharmacy and technology industries, which are constantly advancing and deserve to be compared to transplantation and established therapies, especially as the figure on the right shows that diabetes is set to grow exponentially over the next 20 years. So these illustrations show just some key parts of pancreas transplantation, islet transplantation, and of course the nifty device shows a form of new insulin therapy. So what's the aim? We want to determine which newer therapies can improve glucose stability and other outcomes. So, population, type 1 diabetes, undergoing renal transplant. And the intervention and comparisons will be pancreas transplant, islet transplant, and any form of insulin therapy. So our primary outcome will be HbA1c, to look at the glucose metabolism, and our secondary outcomes, as it stands, are renal function and cardiovascular risk assessment scores. So, clinical question. Is pharmaceutical intervention combined with renal transplantation superior to double transplantation in patients with type 1 diabetes? Our hypothesis is that, if not now, they will be superior to invasive methods. And the clinical or research implication to this is that the level of surgical need for type 1 diabetes patients may decline in the future. So, this is our systematic search key. The first domain refers to the population. The second domain refers to the renal transplantation of the population, and the third domain refers to the different types of therapies combined to the renal transplant. There is one Prospero-registered study that was due to finish in 2021, but it hasn't so far, which is good news. So, some key articles. We actually went through two feasibility checks, one for the islet transplantation and one for the pancreas transplantation. And a couple of those studies are single arm, which we will include. In terms of articles, we are down to 742, which is still a massive number, but the Cohen kappa is good. I think we're just going to keep at it, and that'll go well. So the topic is feasible. It's registered on Prospero. We've removed the duplicates, and we've gone through the titles and abstracts, and hopefully early next year we'll go through full texts. So, second project. Comparing liver transplantation to systemic and regional therapies in unresectable hepatic malignancy. A little bit of background. So, the liver is the most common site for metastasis. It's actually more common to come across hepatic metastases than primary hepatic cancers. Up to 50% of colorectal cancer patients unfortunately develop colorectal liver metastasis. And the liver is actually it's the most common place for metastasis in the body. The good news is, up to 80% of metastases are confined to the liver. The bad news is, the majority are inoperable or unresectable. liver transplantation is an option for unresectable primary or metastatic cancers in the liver. Now, sticking to these figures, I'd like to tell you the aim. So we want to assess the effectiveness of liver transplantation in different oncological diseases. The most recent studies, which seem to be popping up over the past couple of years, show that it is useful. Now, the population, patients with inoperable liver cancer, intervention, liver transplantation, and we'd like to compare liver transplantation to chemotherapies or radiation therapies, any established form of treatment at the moment. And our outcome at the moment is overall survival, which we probably would like to add to in the future. Clinical question. Is liver transplantation the best option to treat patients with inoperable cancer? Our hypothesis is that it is the best option, but probably not in all forms of metastasis or liver cancer. But what's the research implication to this? So more patients with unresectable liver cancers could be placed on transplant waiting lists, ultimately giving them a second chance. We've got 4 domains in this. This is just a preliminary search, but the first domain refers to the liver neoplasm, the second to the transplantation, the third to the comparing forms of treatment, and the fourth, the outcome. There are a few registered Prosperos at the moment. None of them are finished, and they've all appeared very recently. So key articles are split into 2. One's for colorectal liver metastasis and one's for primary liver cancer. We probably will add to those, such as neuroendocrine tumor metastasis. I think it's important to get an answer for every single one of these, whether liver transplantation is the best treatment. We'll subgroup that. So, first project, we plan to finish in June of 2025, and the second project, realistically, in February of 2026. And I'd like to finish on a quote that's really close to my heart, which is, a little bit of science distances you from God, but a lot of science brings you closer to Him. And that was said by Louis Pasteur. So thank you all for your attention.
It's not a question, Arnold. I would suggest something to look into this. Okay. And you may want to add 2 chapters to your thesis. Despite the fact that we have the insulin pump, just like when we had a very good dialysis, it was developing, all of us thought that, oh, if one can live for 30, 40 years with dialysis, why then we need kidney transplantation? Mm-hmm. But it didn't happen. We are doing more and more kidney transplantation. Mm-hmm. So is for the pancreas transplantation, because we need, despite the best insulin pump system we have, which is existing more than 10, 15 years now, still we are doing it. The reason is, for some reason, in morning 3 a.m. and 5 a.m., the whole body metabolism changes. So you want to do some research on that, you may want to add something. And that's the very important thing. It's not the insulin and its imbalances. It's the hyperglycemia and hyperglycemia-induced changes in the cells. It causes the damage, and thereby the kidney damage and other things coming, which is good. But one of the problem happens is, you will see that we used to do pancreas transplant at a younger age. Now, most of the patients are beyond 55. What is happening is, we are getting more and more patients when you cannot transplant anymore because of the morbidity associated with. Yeah. So this is one. And second thing I'll discuss you during that things, okay?
Okay.
Congrats for your presentation.
Thanks.
In your first part of your project, you mentioned islet transplantation is useful, but for less time. Why do you think islet transplantation is less sufficient than whole pancreas transplantation?
That's a really good question. So I think it comes down to the viability of the beta cells. I think when you take it from the recipient, you have to take this to a lab, you have to process the islets, and then you have to infuse them, probably through the portal system. Some of them might lose viability during the processing, and others, interestingly, there's a theory that some enter the portal system, some colonize, start doing the job, start producing insulin instantly, but others get flushed out. So actually, we spoke about this probably a couple of weeks ago, that you actually need about 3 pancreases to have a really good islet transplantation, a successful one, and to induce insulin independence.
Thank you for your comprehensive answer.
Thanks for the question. Good one.
Congrats on your second topic. It's a very interesting and controversial one. But you mentioned that less invasive methods will be superior, if not now, then very soon. Can you elaborate a little bit on that, please?
Yeah, so on the first topic, yeah. So basically, we spoke about it earlier with another colleague who's doing CGM. So this technology is advancing, constantly at actually scary rates. These advanced forms of insulin device are actually coming out like iPhones, and I think it's inevitable eventually to have a device that can administer insulin at the correct time. And there's actually something undergoing FDA approval. I'm waiting for it to come out, and I can't wait for it to come out to see the results that it offers. It's called the islet, and that's actually dual system, so it's actually going to give the patient glucagon as well, just in case there's an insulin spike. So that'll be good.
Congratulations on your presentation. I was wondering what could be some confounding factors in your populations?
Great question. So if you look at a pancreas recipient or an islet transplant recipient, always surgeons prefer to choose a healthier person when it comes for the pancreas transplant, because it's a super invasive procedure and it requires a much higher level of cardiovascular fitness. Another confounder among the studies would be the different types of insulin therapies. They all differ. The way the patients administer insulin, or when they administer it, it could affect the results. And another thing would be the amount of care that the patients receive. I think if you're going to receive a pancreas transplant and a renal transplant, or just a renal transplant, I think if you're having double transplantation, you're probably going to get double the amount of specialists that see to your condition.